Hi everyone, thanks for joining. We'll give it a few more moments before we kick off, just to make sure that we get as many people in as possible. Let's settle in. Alrighty. All right, let's get it started. Welcome everyone. Welcome to today's webinar, Malnutrition and Frailty in Older Adults: The Importance of Screening and Early Intervention. My name is Ryan. I'm the marketing manager for SSS Australia and also your moderator for today's webinar. I'd like to begin by acknowledging the traditional owners of the lands from which we join today's session. I'd like to pay my respect to both elders past and present and to any First Nations peoples who have joined us today. Just a few housekeeping matters before we kick off today's presentation. This webinar is being recorded and will be available for viewing by SSS Australia customers after the presentation. We should have hopefully some time at the end of the webinar for a Q&A session. So if you think of any questions during the presentation, please pop them into the chat box and we'll try to get to as many as possible at the end. Keep an eye on that chat box as well, as I'll post a link in there to the feedback form at the end of the presentation. This is how you can let us know your feedback on the session, as well as request your attendance certificate for your CPD. Lastly, keep an eye on your email inboxes tomorrow, as we'll be sending out a follow-up email to everyone who registered with resources from the webinar, including a link to the recording, as well as that survey again, just in case you miss it today. So everyone who registered will get the email. So if you have a colleague who couldn't make it today, they'll be able to access the recording and still get their certificate for CPD. So keep an eye out for that tomorrow. I'd now like to welcome and introduce to you our speaker for today, Louise Murray. Louise is an accredited practicing dietitian specializing in aged care nutrition and food services. She started her career in the hospital setting, but through family connections, she started assessing menus in residential aged care for 6 months, 6 months after graduating. This ignited her mission to remove party pies and sausage rolls from aged care menus and to improve the food quality for older people over the past 23 years. Louise's consultancy, Nosh Dietitians, specializes in consulting to aged care organizations, supporting older clients in the community and mentoring dietitians to become leaders in aged care nutrition. This webinar also wouldn't be possible without our vendor partner, Nutricia, and their Fortisip family of products. Fortisip are ready-to-drink nutritional supplements that are high in calories and protein. Fortisip comes in many delicious flavors and encompasses several ranges to meet a variety of different nutritional needs, including compact protein, multi-fiber, and plant-based drinks. For more information about Fortisip, please reach out to your SSS Australia account manager. All right, so without further ado, I'd like to pass it over to Louise to get started. Thanks, Louise.
Thanks, Ryan. Welcome everyone today. We're going to be talking about the very hot topic of malnutrition and frailty in older adults, with a very big thank you today for Nutricia for sponsoring this event. So today we're going to be looking at how we build a strong awareness of what malnutrition is, but also the impact on older adults, both within the community and also in residential care. Hopefully, we're going to equip you with the confidence to identify the early signs of malnutrition and also to empower you to make screening for malnutrition standard practice in whatever role that you have in your healthcare setting. We want to encourage immediate evidence-based intervention to address malnutrition and improve patient or client outcomes. So what are we talking about here with a number of people that are actually impacted by malnutrition? So within the community, up to 17% of adults are malnourished and up to 63% are at risk of developing malnutrition. And a recent study that was done last year in residential aged care shows that 40% of residents were considered malnourished, with 6% severely malnourished. And just a point to note here that those with dementia weren't included in this study, so we can assume that that rate would actually be higher if residents with dementia were also included. So why is this such a big problem? What's the deal with malnutrition? So we want to also just touch on frailty, because that's also something that is talked about a lot with older adults. And what this is a state of reduced strength and resilience. So it makes the body less able to cope with stresses like illness or acute infections or other injuries. Frailty is often considered a normal part of aging, along with unintended weight loss, and we can now safely say that it is not just a normal part of aging. We have a growing aging population in Australia and across the world. This shouldn't be a new fact for you. But what this also means is we're going to have higher rates of malnutrition, frailty, and sarcopenia within our community and residential aged care settings. There are high rates of unrecognised malnutrition and frailty, regardless of the setting. And it's also a preventable decline if we have more timely action, but also earlier identification. The multidisciplinary team role is absolutely crucial, but what I'm seeing is it's often not occurring. And hopefully this conversation is something that we can get started to help everyone identify what their role is within the malnutrition space, but also help to coordinate between other allied health and nursing and GP practice services as well. So malnutrition can also be called undernutrition. So it can be defined in a multitude of ways, depending on what evidence or resource you're looking at. But essentially, it's an inadequate intake of protein and or energy over a long period of time that results in loss of fat stores and or lean muscle stores, and includes starvation-related malnutrition, chronic disease, acute disease, or injury-related malnutrition. So what does malnutrition look like? And these are things that you probably see within your practice, regardless of what setting that you're in. So people that are displaying visible signs of weight loss. So anecdotally, for me, when I can see that someone has lost weight, and you'll often see it within their face, they've already lost 5 to 10% of their body weight. So when you're noticing a physical decline of weight when someone looks like they've lost weight, it's already significant. They might struggle to squeeze your hand tight. And that's a really simple thing that we can do when we're seeing our clients or our residents. They might have loose dentures. So when we lose weight, our dentures don't fit the same anymore. So they might slip out of their mouth, or it just is really uncomfortable or painful to chew when they're eating. They struggle to complete a sit-to-stand test, and this is where it's really important that we involve the physio as part of these malnutrition conversations. They could be unsteady on their feet, suffering a bereavement. So often we see significant malnutrition progressing when someone has lost their spouse that they've been living in their home with. So it may be that they've also lost a spouse and then going into care. So there's significant factors that impact someone's malnutrition because of bereavement, which can also initiate things like depression. When there's disinterest in food or a lack of appetite. So one of the things that I really recommend is just ask some basic questions. So one of the things that I like to do is ask, what's your favourite food? You and I will probably be able to tell you, oh, what is my favourite food? Is it something that I eat with my family, or is it something that mum used to cook when I was little? But if you ask an older person who's not interested in food or has a poor appetite, they often can't tell you what their favourite food is, or you can see their face scrunch up, or that's, you know, they might do a bit of the bob of the head, like, you know, I could take it or leave it, and not really provide you with an answer. So sometimes just a really basic question can give you an idea of whether someone is disinterested in food. Any recent hospitalisation or acute illness or infections can be a trigger for malnutrition, and also a weakened immune system. So we've got this circle of malnutrition, frailty, and sarcopenia here, and it's a bit like the chicken and egg, which comes first, but they all have a role in the development of the other. So we've talked about malnutrition in being the inadequate intake of protein and energy for that person's needs. Sarcopenia is a word that is becoming a lot more common now, but it's the age-related loss of muscle mass, strength, and function. So this is something that it's inevitable, but the rate at which sarcopenia progresses and develops is really dependent on protein intake and resistance activities as the person ages. And also frailty, as we talked about before, being a lack of physiological reserve to deal with things like illness or infection. So for those older adults, and when we talk about older adults, it's over 65. So I just wanted to clarify that. You ask my parents who were in the early 70s and they say, no, we're not your people, but it's anyone over 65. So they'll commonly present with both frailty and malnutrition. And then on the right-hand side, we've got malnutrition and sarcopenia having a 5-fold higher risk of development when malnutrition is present. What does poor nutrition sound like? And these are phrases that I hear all the time in seeing clients, both in the community, but also in residential care. So first one is, I don't need to eat as much anymore. I'm not doing anything, or I'm not as active as I used to be. This is a really, really common one, and it's a good one to listen out for. I just don't feel hungry like I used to. And that's that trigger to say that someone doesn't have the same appetite that they had previously. This can be because of malnutrition or as a result of malnutrition, but also we need to factor in the anorexia of aging. So as we age, our appetite isn't going to be the same because our body's hormone levels adjust so that we don't get the same appetite signals as we did when we were younger. Over on the left, I'll just have a cuppa and some toast for dinner. So I call this tea and toast syndrome because it's something I see all the time. It might be toast with a cup of soup. At the end of the day, we know that these things are not going to provide the protein. It's not a full meal, but it's something that if someone has a poor appetite, they're more likely to provide for themselves at home. Over on the right, there's no point cooking for one person after my husband or wife has passed away. This is a really common one because when there's no desire or interest or necessity to cook for another person, the interest in cooking for themselves often declines. And so this is something that we really need to factor in, along with what we were talking about before in terms of the bereavement or loss of that partner that they've had for a long time. And food doesn't taste the same anymore. So it could be for a variety of reasons, but one of the most common ones, which we don't talk about enough, is the lack of smell or the sensation of smell. So there's 60% correlation between the ability to smell food and taste food. So this is a really simple question that you can ask your clients or your residents. Does food smell the same anymore? Can you smell that cup of coffee? When the hot meal comes out of the oven, what does it smell like to you? And that's when you'll be able to identify if someone's taste sensation has also reduced. Remembering that the smell and taste of food is that first stage of digestion because it gets our salivary glands going and also the gastric acid secretion. So the sense of or smell sensation, if that's reduced, then it does have a big impact on their ability for appetite and digestion as well. What are the consequences of malnutrition? So we know the increases of morbidity and mortality, but specifically there's an increased risk of falls and fractures. And we know that the health ramifications of someone who's had a significant fall and fracture. Development or chronic pressure injuries, increased infections and poor wound healing, increased hospital admission, which we know as soon as we have longer stays in hospital and acute illness or injury, then that's also one of those risk factors for malnutrition, functional decline, and also a lower quality of life. So what are some of the challenges to good nutrition that we see with older adults? As I mentioned before, the anorexia of aging or the reduction of appetite is one of the most significant ones that we see because people don't have the desire to eat as much as they did before. The early satiety or feeling of fullness. So you might notice that mum or dad or one of your clients has half of their meal and you can see their face just go, I've lost interest, I'm full, I don't want to eat anymore. And it's really hard to encourage someone to eat when they already feel full. Someone's inability to feed themselves. As soon as that occurs and we have to rely on someone else to feed our older adult, then the rates of malnutrition start to increase. Increased requirements, so infection or fractures, particularly after a significant fall and fracture, can be a really big challenge to good nutrition, both from an intake but also a requirement perspective. Side effects of or interactions with medication can be a big trigger for challenging nutrition requirements. Dislike of diet, texture modified diets. I would love $1 for every time that I've heard someone say, Mum or Dad doesn't like her puree diet. Can we get that changed so that she can eat more? Having multiple medical conditions or comorbidities is a challenge for someone to meet their nutrition requirements. And also dental issues. So are there pain? Do they have ulcers? Do they have loose dentures? So dental issues can be a really significant factor on how well somebody eats. So we're going to move into, we know now about malnutrition and the challenges that it presents, but how do we identify it? And this is where malnutrition screening comes in, and you're going to hear a lot about this in the coming months, because it is now part of the strengthened aged care quality standards for both residential aged care as well as for home care providers. So we also have the evidence-based guide in Australia and New Zealand for community-based clients for malnutrition. So we have requirements that we need to make in terms of the standards, but we also have guidelines that we can follow for those community dwelling older adults as well. And we have some international guidelines which we'll go through within this presentation on the practical guidelines for clinical nutrition and hydration in geriatrics or older adults. And the one consistent message that we have here is that regular screening to identify malnutrition early and to provide treatment early has better outcomes for our older adults. And these resources are available to you, and the reference list will be provided here. So why do we screen to identify those at risk of malnutrition? So unintentional weight loss can be an indicator of muscle mass loss. And so we need to make sure that monthly weight monitoring at a minimum is being done both within the community and residential aged care. So something I see with our community clients is their weights are often not monitored regularly. It may be that they don't have scales at home, or it's not something that's part of the onboarding assessment when somebody starts under a home care package. Weight monitoring is a component of every malnutrition screening tool, so we need to be understanding what somebody's weight tracking is. It's vital to integrate into all settings so that we can identify who is at risk or who has already developed malnutrition and or sarcopenia. The Mini Nutritional Assessment, or MNA, is a validated screening tool. It was actually developed for older adults, which is why I personally think it's the most useful tool. And we now have evidence to show that the short form, which is only 6 questions long, is also validated and a useful tool to be able to identify or screen for malnutrition in older adults. The malnutrition screening tool can also be used. However, as we'll talk about shortly, it's not validated to be used in the community setting, so it's not as recommended if that's the setting that you work in. So here's a bit of snapshot on the Mini Nutritional Assessment short form. And here's the parameters that we look at: changes to food intake, weight loss, mobility, any acute disease or psychological stress, and that includes cognitive decline, neuropsychological problems, and also BMI. One thing that I do want to note here is that BMI alone is not a predictor of malnutrition. Something that we as dietitians get quite a lot is referrals for people to lose weight because they have a high BMI. Now, a BMI of 24 to 30 within the older adult setting is considered a healthy weight range, because we know that having a higher BMI is more protective, particularly against things like adverse outcomes with falls. Malnourished obesity is an issue that we see on a regular basis. So as soon as there is unintended weight loss, this is where we need to be mindful that malnutrition can still occur even if someone is of a healthy weight or an overweight or obese range. So the MNA short form is validated in all settings, whereas the MST is validated in hospital but not in community settings. And that should be a really good guide to choose which one that you use. One more thing to note in terms of BMI within the MNA, If you don't have an accurate height measurement of the person that you're working with, there is a chart to help you. You can measure the ulnar length of an individual, and there is a chart on the MNA website where it gives a guide, whether it's male or female, as to what their estimated height can be. So that's an easy guide that you can go and access as well. So this is going to be a little bit small for you to see, but the M&A short form is on the left here, and this is where it's only got 6 questions that we talked about. So it's very simple to do. We're going to have a go in a couple of minutes. But this is just to give you a look at what it is. So the recommendations for intervention on the right-hand side. So if someone is normally nourished or not at risk, we recommend to rescreen for if they've had an acute illness or a hospital admission, for example. Otherwise, it's annually in those who live in the community, or every 3 months for those who live in residential care facilities. If the score is identified as being at risk of malnutrition, so that score is between 8 and 11, if there's no recent weight loss, then we can just continue weight monitoring and rescreen every 3 months. However, if someone is at risk of malnutrition with recent weight loss or is malnourished according to the M&A short form, then we need to look at the next strategies of treating it. So some nutrition intervention, dietary advice, it might be food fortification, which we'll talk a little bit more in depth shortly, oral nutrition supplementation, regular weight monitoring. So we talk about a monthly weight monitoring, and then further in-depth nutrition assessment. So this is where a dietitian referral is absolutely crucial to continue the assessment and treatment of malnutrition, regardless of the setting. So the one thing I really like about the M&A short form is that it's easy to complete, but it also gives you a really good guide as to what your next steps are, which is important for you as health practitioners. So this just shows in a little bit more detail on when we're looking at when we rescreen. So other than if someone is normally nourished and living in the community, it should be done every 3 months. Okay, so we've got a QR code here. So if you've got your phones handy, you can scan the QR code and it will bring up the M&A short form. I've got a really quick case study here, so it's really simple to be able to pop that information into the M&A short form. So we've got Jim here, who is an 80-year-old gentleman, and he still lives at home. He says he's been eating less than he was previously, and he's lost 5 kilos since his last check-in 3 months ago. He still goes out, but he's not as steady on his feet, so it's becoming less frequent that he's going out. He doesn't have any cognitive impairment or any recent illness or infections. His BMI is 20, but he says he's always been on the slight side. So what is his screening score? So I want you to have a go at this, but let's have a look at each section here so we can just quickly fill it out. So we would probably need some more information on how much less he's eating, but let's go on the conservative side, and we can show that he's got moderate decrease in food intake, so he scores a point there. His weight loss is more than 3 kilos, so he gets a 0 for that one. His mobility goes out, so he gets a 2 for that one. No psychological stress or acute disease, so he gets a 2 there. He doesn't have any dementia or depression, so he gets a 2 there. And in terms of his body mass index, his BMI is 20, so he fits into the range of 19 to 21, so he gets a 1 there. So his screening score, based on what we've just talked through here, is 8. So he comes in at the at-risk level, but remember that he's had recent unintentional weight loss. So he's someone that we would need to identify as needing action and a dietitian referral. So who should screen? Basically, anyone that looks after older adults should be doing malnutrition screening. It's now a requirement under the new Aged Care Act that anyone under home care packages and living in the community under nursing support, under a home care package or support at home, as it will be called now, will need to have regular malnutrition screening. And as we've just talked about, it should be 3 monthly unless someone is identified as well nourished. You can see here that in terms of where the nursing role is, it's if someone is screened as being at risk, but with unintentional weight loss or malnourished, a referral to a dietitian can be done or should be done, and early intervention can be initiated if there is some delay to see a dietitian. And we'll talk about some more options that you have as nurses within that role. So malnutrition's identified. What do we do now? So some of the methods that we use as dietitians is a food-first approach, and this should always be encouraged. What foods that can we initiate or encourage or obtain for somebody to ensure that they're still eating as much as possible rather than going straight to supplementation as a first line? 3 regular meals and 3 mid-meal snacks, which actually sounds like a lot, but when you've got someone with poor appetite, we want to have small, frequent meals and snacks to try and stimulate their appetite. As soon as we have long breaks between meals, we find in clinical practice that somebody tends to eat less and the appetite is not triggered as much as if there's really long gaps between when they're eating. Food fortification, so we talk about adding protein to foods. So it could be in the form of making sure, if, let's say, for example, it might be a pumpkin soup, can we add lentils or some other food that can provide some additional protein? So food fortification is about, yes, providing calories, but it's calories in the form of protein, because that's what our bodies need to try and regain that loss of muscle mass. Oral nutrition supplements have a place within the treatment of malnutrition, and also remembering physical activity. So if we want to rebuild lean muscle mass, which has been lost, then we need to make sure that we're doing resistance-based activities as well, which is where your referrals to an exercise physiologist and or a physiotherapist are crucial for our older adults. Why is nutrition support so important? We want to maintain the nutritional status for our older adults for as long as possible. It's to regain their lost weight and particularly lean muscle mass, and to restore the optimal function in daily activities, so particularly maintaining the independence for as long as possible, and promote healing. So whether that be a chronic infection or illness, we want to promote healing through stronger immune function. I'm going to give some more information here about, we talk about protein as dietitians for older adults just as much as any gym junkie. So this is something that's really important for us to talk about. And there's guidelines here that we tend to use from the ProTage study, which it's from 2013. So it's an older study, but we actually, the evidence that we have now still supports those guidelines. So 1.2 to 1.5 grams of protein per kilo of body weight. So if you think about, an average 70 kilo person, they'd probably need about 100 grams of protein in a day, which is actually quite challenging when someone has a poor appetite. It can be up to 2 grams of protein per kilo body weight for those who have severe illness, injury, or significant malnutrition. So you can see where the role of food fortification and oral nutrition supplementation really comes in play here. The more malnourished somebody is and the more other comorbidities that are present. We want to aim for 25 to 30 grams of protein per meal. So it's not like we can go, right, someone's got a 100-gram requirement for the day. We're just going to put the bulk of that in the evening when they're eating better. We want to spread it out over the day. The reason for that is because there's an anabolic or a muscle building threshold of dietary protein as we get older. So let's say, for example, you and I both had a main meal. There was 30 grams of protein. When we're in our younger years, we can use that protein a lot better to build more muscle, whereas this is not as easy to do as we get older, just because of the impaired response to nutrients, but also the hormones involved, which alter a little bit as we age. So we're not able to use the same amount of protein to build the same amount of muscle as we get older, which is why we recommend having protein spread out across the day. Talking about a food-first approach, so I've got here some meals that these were photos that we took for residential aged care, but you can see, so the top 3 main meals on the left is what we would consider a main medium size. So it's at 90 to 110 grams of cooked protein. So that's kind of just to give you an idea of what it looks like on a plate. So when you're going maybe to assess somebody in their home and you can see that they're really only eating half of that, you're already getting a picture in your head that, oh, okay, maybe they're not eating as much as they should. Maybe we need to start looking at malnutrition screening, looking at their recent weight loss and what we might need to do in terms of a food first approach. Food fortification, as I mentioned, we want to focus on protein being added as the form of energy or calories. So adding dairy, and I'll tell you why shortly, but dairy is the most beneficial food fortification that we can do. So we're talking about, if someone has fruit in the morning for breakfast, adding 100 to 150 grams of yogurt. If someone is having porridge, for example, for breakfast, we could add some skim milk powder to boost up that protein and dairy intake. We want to have small frequent meals and mid-meal snacks when appetite is low to try and stimulate that appetite. And reducing the empty calories. So I spoke before about tea and toast syndrome. That's really what we would call empty calories because there's no to minimal protein consumed within that meal. And remember, food is only nutritious if it's eaten. So we've got to make it taste really, really good for someone who may have poor appetite, may not smell food the way they used to. And so the taste is different, which is why we often see older people adding a lot more salt to meals than we maybe would in our younger years because the taste sensation is different. So we've got to jam-pack that meal full of flavour while it's cooking or being cooked rather than adding salt at the point of service or at the table. So this is a really good snapshot here that we've got some protein-rich foods, and it might be that we're adding, I like to think about it, rather than swapping something out, that we're adding something in. So let's say over on the right-hand side, we've got just a standard muffin there. Can we add a smoothie or can we add a full milk Milo or a coffee with that muffin rather than swapping it out and they miss out on something they really enjoy? But these are some really good ideas on the left of things that we can add to add protein and look at it from a food fortification point of view. And these resources are accessible on the Dietitian Connection website if you need some really visual guides for some clients or for your dietitians if you're working in the residential or home care setting as well. So I talked before about adding dairy as an option for food fortification, and I'll talk a bit more now about that because we have really good research, Australia-based research, to show that when we encourage or provide the opportunity for an older adult to make 3.5 to 4 serves of dairy per day, then they can improve their malnutrition status. So if someone is malnourished, we can actually get them up to being at risk of malnutrition. We're improving that M&A score by providing 4 serves of dairy per day, which is a really significant piece of work for us because it shows that we can rely on food first and still get that malnutrition improvement. There was further research done, so that the study I've just shared with you was the first lot of research. This has been carried on by the same researchers in Melbourne, and they looked at 60 aged care facilities and they looked at taking the menu from a standard 2 serve of dairy per day up to 4 serves of dairy per day. So you can see that the actual protein intake itself has only gone from 58 to 69. So it's not hugely about the protein intake. It's about all of the combination of amino acids in the protein in dairy, but also some of those essential minerals, so your calcium, phosphorus, magnesium as well. And what this research showed was that there was a 33% risk reduction for all fractures in these residential care residents, 46% reduction for hip fractures, and 11% reduction for falls. So there were really significant results just by adding an extra 2 serves of dairy to the standard aged care menu, which is, it's phenomenal. So let's talk about if we cannot meet someone's protein requirements through the diet, what else can we do? So this is where oral nutrition supplements come into play because they provide additional nutrients like the protein and energy, but also the micronutrients that we need for immune function and wound healing, for example. It's commonly used in addition to a usual diet, They can provide, so it's what we call a complete nutrition option. So it can provide all the nutrition needs if required, but we usually do it as a supplemental option. So it's in addition to the usual dietary intake. So the goal with using oral nutrition supplements is increasing muscle mass and strength, improving physical function, but also reducing mortality and other comorbidities or complications of malnutrition. So going back to the ESPEN guidelines that we referred to earlier, we've got 3 recommendations here that are really significant and specific to the use of oral nutrition supplements. So supplements should be continued for at least 1 month, and the efficacy and expected benefit of oral nutrition supplements should be assessed every month. So the takeaway from this is that supplements are not a set and forget. We don't start someone on supplements and then come back to them in a year's time and go, oh, let's just check how things are going. It needs to be assessed and monitored every month. Oral nutrition supplements when dietary counselling and food fortification are not sufficient to reach nutritional goals is where we see the most benefit from using supplements. So the next recommendation is compliance or the consumption of ONS should be regularly assessed. So things that we see really impact on whether someone consumes their supplements is the type, flavour, texture, and time of consumption. But the other thing that we see quite a lot is the temperature of the ONS. So I'll talk about this shortly, but you know, if you've left the milk sitting on the bench for 2 hours and it's just room temperature, it's actually not that nice to drink. And that's how I consider the same thing with supplements. So the takeaway here is we want to reassess after 4 weeks to make sure that the recommendation we've made for the oral nutrition supplementation is actually suitable for that individual. Because as we all know, we are all very, very different in what our taste and preferences are. And the third recommendation I wanted to share here was in terms of the nutritional content of the oral nutrition supplements. So it should provide at least 400 kilocalories and 30 grams or more of protein per day in the oral nutrition supplements that are prescribed. So this is where supplement types matter. And it's a lot more difficult to reach these nutrition targets using fruit-based supplements. So milk-based supplements are always preferable where possible. So what's the indication for using supplements? The goal is for nutrition support, not as a replacement for meals or snacks. So we still need to provide it in conjunction with that dietary advice. And this is where your dietitians really become your ally, particularly in the home care or residential setting, because this is literally what we're able to do is assess what is the best option for that person, depending on their other comorbidities other than malnutrition, as well as all their preferences, ability to meet their requirements through food fortification, as well as supplementation. So supplements are to be prescribed under the guidance of a dietitian for ongoing assessment and monitoring. So here we're going to talk about the evidence of why using and when using supplements is really effective. So they're clinically proven to manage unplanned weight loss in old adults in both the residential aged care as well as the community setting. So you can see here that we've had weight increase in both settings. Some other specific benefits that have been identified with and studied with oral nutrition supplements is significant reductions in hospital admissions, and we all know the healthcare burden with hospital admissions, a 67% reduction in length of hospital stay, a 30% reduction in antibiotic use. So again, that comes back to that infection, infection prevalence for those who have malnutrition. And we can see that we still get really good benefits, regardless of whether it's residential or community settings. So the great news is oral nutrition supplements are covered under support at home packages. So when they're prescribed by a health professional and ideally a dietitian, as we've just talked about, we're able to provide the assessment and monitoring for nutrition support and not just about the oral nutrition supplement. ONS can be accessed through local distributors and provided through home delivery, so that the burden of our older adults having to go and obtain the supplements is strongly reduced. And we also now have evidence to show that the low volume supplements, so like the Fortisec compact protein that we have here, shows a higher compliance compared with a standard supplement that is in the 200 ml range. So the Fortisec compact protein is 125 ml. So if you think about having half a cup of something along with morning tea, then it makes it really easy for them to consume. And you can see why there's a higher compliance or consumption rate with the lower volume. The most benefit will be seen in the first 3 months for someone starting on oral nutrition supplements, which is why that is when the assessment and monitoring needs to continue in that first 3 months. A variety of flavors really does help reduce that taste fatigue and just create a bit of interest in the options of nutritional supplements. So we also know taste preferences are very individual. So I might like the cool red fruits, which that's actually one of my favorites, but someone else might prefer the neutral because it's not sweet. So having a variety of flavors is really helpful there too. And as I mentioned, supplements should be provided cold, or they can be gently warmed unless the individual specifies that they don't like either of those things. And it does happen. I do have some residents in aged care that prefer it just at room temp, but on the whole, it's much better when they're consumed cold. So diving into some practical nutrition challenges, and these are things that, particularly as nurses, your role is going to be really pivotal in the community to identify some of these issues which are going to contribute to malnutrition. So these are things that you may have picked up in your onboarding or original comprehensive medical assessment. Food security is becoming more of an issue that we see in our daily practice than maybe it was 10 years ago, particularly with the cost of groceries. So for those who are living independently, do they have family and friends to help support them? Can they access food at the shops? Do they have the income to buy adequate food? And we know that the cost of some of those high protein options like meat can be a little bit more pricey than, say, protein containing foods such as dairy or eggs. So it's really about finding what protein options are available that are also affordable for our older adults in the community. Food provision. So are our older adults who are in the community buying the right ingredients to make the meals that are nourishing to help them meet their nutrition goals? If there's any cognitive impairment, can they still follow a sequence of steps to make a meal or follow a recipe? Can they safely use equipment? And these are things you might need to get your occupational therapist in. Again, the multidisciplinary team is so important to help identify where we can support older adults who may need additional supports. And food consumption, are they eating regularly or are they eating enough? Another thing that we see is someone may eat breakfast and then they might just have, cheese and crackers for lunch and maybe a smaller dinner because they're not as hungry. So we need to actually be asking those questions. What are they eating rather than are you eating? So keep those open-ended questions. And having some social settings so that someone is not eating alone all the time. Social isolation, is a really big trigger for someone to develop malnutrition, because we all know that we eat better when we eat with others. And some of these practical supports, so particularly as nurses, I kind of look at nurses as that pivotal role. So you're kind of the ringleader to assess and bring in the health professionals that are needed to support within the multidis team. So things like meal preparation and delivery, do they need in-home meal delivery options for them? Do they maybe need it half of the week? So there are different options that we can choose for helping somebody within the community. Cooking support. Do they want to still be able to go and choose the different foods that they want to have to eat, but they might just need help with chopping up vegetables, for example? And as part of the nursing assessment, we also need to be asking the questions of, is food security actually an issue? Are people eating less because of the cost of food? Are there cognitive changes that mean that someone is not eating as well as they were before? And one of the best recommendations that I can give you is to open the fridge. Go and see, what have they purchased? Ask them, what are you cooking for dinner tonight? Talk me through what you're cooking. Are you going to cook it on the stovetop? Is there a packet sauce that you can add into that? Finding out more details. And this is where, as dietitians, we spend a lot of time asking these questions because sometimes the information you get may not be the full picture of what's happening. So I've got a case study here. This was actually one of my home care clients. Obviously, her name is not Mavis, but this was her situation when she was referred to me. She was 79 years old and living alone in an upstairs unit. She had some really significant dental work 18 months prior, so it changed the way that she could eat. So she was choosing softer foods. She wasn't really eating red meat, and she could manage chewy foods, but she was really changing the way that she was eating because of her dental ability. She had had weight loss of 15 kilos in this time, and she'd been unable to gain any weight for 6 months despite trying. So that's really significant when someone is actively trying to gain weight but can't and still losing weight. That's a red flag for us. So if they go to the GP and this is a question that comes up, or you're going in for a home visit and you're noticing that their clothes are really baggy around their waist, these are really important things to identify so that we can look at what the weight loss has been like. So for her, she was using a walking stick, but I noticed she was holding onto furniture as she was moving around the unit. She did still cook and shop independently, but she had a really heavy carer burden in that she was caring for her ex-husband who had chemotherapy treatment at that time. Another interesting thing that came up for her was she'd had a history of gastric banding in her 40s, so she'd always struggled with being overweight. So when she started losing weight, she was actually really happy about it because she'd always been trying to lose weight. But then that flipped into going too far where it became an issue for her general function and being able to carry out her daily tasks. And that was when she identified to her GP that maybe she actually needed some support. So what are the big ticket items for her? So I identified her as having moderate malnutrition when I was referred to see her. And this is something that is really important to note. We as dietitians get referrals very late in the piece, and it's very difficult if we're looking at reablement or being able to regain lost weight and build up lean muscle mass. It's very hard to do when moderate to severe malnutrition is already present. So early screening and intervention is really, really vital, and this is why we're having this conversation today. Mavis was still able to cook and shop independently. So we talked about what protein requirements, and I actually gave her written instructions on what I wanted her to buy and what I wanted her to prepare at home. And we found some convenience options for her that she could buy at the supermarket to make her job a little bit easier. We increased her fibre because she had issues with constipation, which then was affecting her appetite, and her interest in cooking was reduced. So sometimes we need to dig some more to find out what else is going on, and this was something that came up for Mavis. After 2 months, we realised that as much as the dietary changes and implementations were helping, they weren't helping enough. And so we did introduce oral nutrition supplements at that time. She had really good tolerance, and it was funded by her home care package. So it was accessible to her because food insecurity was an issue. And once we started to gain some weight back on for her, she felt well enough and strong enough to get back into her weekly exercise classes. So it was a win for her because it meant that she was able to go and build more muscle and also get that social interaction, which she had been missing before that as well. So nutrition goals for Mavis, but also generally, are to prevent further weight loss, improve the appetite and dietary intakes. We want to bring that enjoyment of food back as well, and meeting nutrition requirements, but primarily protein. So the key takeaways from today, which I hope you've taken, is malnutrition is often under-recognised and under-treated, which can lead to serious complications for older adults. As I mentioned before, as dietitians, we often get referrals very late in the piece, primarily because malnutrition screening is either not implemented or it's not acted on. So they may see that the score is under 8, but not have a referral pathway there. Malnutrition is not always easy to see, but it is easy to screen. So as we've showed, the M&A short form is super simple. You've got 6 questions, and you've had the QR code there, which these resources are all readily available, so that you can implement malnutrition screening regardless of the setting. early intervention is always key, and everyone has a role to play in addressing malnutrition. So regardless of what your role is within the healthcare setting, malnutrition screening for older adults needs to be in every setting. And hopefully you're going to feel empowered to make a change, whether that be to implement malnutrition screening, teach your team how to do malnutrition screening, change the way that you go in and assess somebody in their home, for example. So hopefully there's been at least one change that you've taken away from today to make a difference in the recognition and treatment of malnutrition in our older adults. So thank you for being with me today, whether you've attended live or caught the replay. And I'd like to open it now for questions.
Awesome. Thanks, Louise. Really fantastic content there. And just as a point that I saw in the chat earlier, that MNA, if you didn't get the chance to follow on for whatever reason, we'll include that in the resources email tomorrow. So you'll have a copy of that in your inbox. So you'll see that I just posted the link in the chat towards that survey. So please fill that out to grab your attendance certificate. But we do have a few minutes for questions. We've already got one sitting here, which is great. Is using sustagen powder or other commercial protein powders available helpful for meeting protein needs, and when is the best time to use it?
So in terms of protein or nutritional supplement powders, they can be a really good first option for someone who hasn't had any nutrition support beforehand. The things that we need to remember when we're using a powder is we need somebody to have the dexterity or the ability to mix it themselves. We strongly encourage that it gets mixed into milk rather than water, so you're still getting that nutrition. As I mentioned in the webinar, having those dairy serves really does help for someone's nutrition status. So yes, it can be a helpful first line, but it may be an option to then consider dietitian referral and further nutrition support. So yeah, it is a good first line, but it's not generally what we would continue someone on for various reasons.
Do we have any other questions while we're in our last few minutes here? Feel free to pop them into the chat. What do you recommend if they are intolerant to dairy?
Yeah, this is a good one. And the one thing, there's two parts of this. Are they lactose intolerant or dairy intolerant? And this is something that gets really commonly confused. A lot of the oral nutrition supplements, and particularly when we're talking about the Fortisip here, it's low lactose or what we would consider to be lactose free. So again, it depends on the actual supplement. So it's not a general, but they're often low lactose. So if lactose intolerance is an issue, they can often still safely have an oral nutrition supplement. If they're intolerant or allergic to dairy, we do now have plant-based options as well. So we can, we've got a lot more choice now in terms of what we can have. But the first question I would ask is it the dairy or is it a lactose issue? Because, we very commonly get feedback from nurses or family members saying, Mum's got loose bowels. I think it must be the supplement because she's lactose intolerant. But it's often that's not the case because they're low lactose. So great question, but there are also plant-based options now as well.
We've got one from Leanne here. Are there any links for regional and remote dietitians that can facilitate a review without a GP referral?
Yeah, so particularly under the Support at Home program, dietitian referrals and assessments are covered under the program. They don't need a GP referral, so we get referrals from home care providers frequently without a GP referral, so that is acceptable. If you go onto the Dietitians Australia website, there will be a link for APDs that you can search within your regional and remote area. There are also dietitians, so I know we do telehealth, so there are other options for telehealth. I know it can be really challenging. I did work in North Queensland for a while, so I know it's challenging in regional and remote areas to get a dietitian. So that would be my recommendation, Dietitians Australia website, or look for telehealth options that are available to you.
Fantastic. All right. Well, yeah, a few more moments. If anybody has any more questions, we still have a few more minutes, so feel free to pop them in. Otherwise, wrap up very shortly. But as just in case anybody's typing at the moment, I'll just say another quick thank you again to you, Louise, for the fantastic content today. Thank you to Nutricia as well for being our vendor partner in this and helping facilitate this education. We've had a lot of webinars actually this month on malnutrition or just nutrition in general. So yeah, if anybody's tuning in for this one, we've also got a few other webinars that we've hosted this month. One kind of centering nutrition and how it relates to Alzheimer's, and that one's available on our website. So feel free to check that out as well. Um, Another query in the chat from Daphne. ONS 4 weeks assessment. Can this be done by an RN or must it be done by a dietitian?
Really good question. Best case scenario is that we have a dietitian involved, particularly when malnutrition is identified or the at risk of malnutrition. So what we like to say is if nurses are implementing oral nutrition supplementation as a first line while waiting for a dietitian to assess, then that's when we would like the dietitian is there to help you with your job. At the end of the day, as nurses, we know that you have a myriad of different things to do. And so that's where the dietitian can be really helpful for you because they're also going to create more of a specific assessment and help guide which oral nutrition supplementation is most relevant to that person. So in essence, could it be done by an RN? Yes. Does it need to be or should it be? I would recommend getting your dietitian involved as well.
I suppose we have a comment here from Jillian who says, she finds that the MNA SF is a recommended screening tool because they use it in their racks, and it shows that actually a majority of their residents are at risk. It's very sad to think that this is where aged populations are. Is this something that you see a lot across a lot of racks or?
Yeah, it is. And I think, thank you for your point, Gillian. I think it's really important to note why that is. And so when we think about the number of residents in aged care facilities who have dementia or cognitive impairment, or they've got a recent acute illness or pressure injury, so all of these things will actually lower their score to contribute to them being at risk. But the biggest thing is that unintentional weight loss, and particularly in the last 3 months, is really a big contributor. So unfortunately, that is where we see, and I'm really surprised that the data that we have, it's not higher because in practice, I do see it's much, much higher for those at risk and malnourished. We're also seeing residents come into care a lot later. People are wanting to stay at home longer. So they're coming into care with higher needs, and often malnutrition is one of those things as well. So for someone who's worked in aged care for 20 years, I do see a big shift, and it has been a observational increase in those who are at risk or malnourished.
Jillian just chucked another question there. So what do you think of the MUST assessment?
Yeah. Again, I think that's very similar to the MST in that it's not a validated tool for use in the community setting. And so for me, and the MUST was developed as a general malnutrition screening tool, whereas the MNA was developed for the older population. So again, MUST is 3 questions compared to 6 in the MNA short form. As you can probably tell, I'm a really big fan of the MNA short form in terms of the specificity and the validity of using it for older adults, regardless of the settings. So that would be where my recommendation and preference lies.
Fantastic. Thanks for the awesome questions, Jillian. Yeah, well, look, I'd hate to keep everyone longer. I'm sure everyone has a busy schedule to return to, so I think we'll wrap it up there. Once again, big thank you to Louise, big thank you to Nutricia. Thank you all for joining us today, and for those who asked some really thoughtful questions. So yeah, once again, just keep an eye out in your inboxes tomorrow for those resources, including the recording, the survey, and the M&A as well will include. So wonderful. Um, Thanks everybody. Have a fantastic afternoon. And hopefully we do have another webinar next year. Not next year. We have plenty of webinars next year, but next week we have one in partnership with Moonliquor and their new dressing. So if that's of any interest, feel free to check that out on the SSS Australia website as well. But so we might see some of you next week as well. But yeah, once again, thank you all very much and have a fantastic afternoon.